Hello, students. Welcome to Concepts of Care for Patients with Oral Cavity and Esophageal Conditions. This is part 3, and this is the most interesting segment in the semester, the gastrointestinal, because as I mentioned before, all the conditions and all the diseases starts in the gastrointestinal, all of them. If we control and we take care of the gastrointestinal, which is also known as the second brain in the body, okay, because of the number of the nervous system involved there. Okay, so I am very excited. I really love my gastrointestinal segment. I truly believe if we eat the proper food, if we have healthy lifestyles, habits, we can control, reverse, and improve our overall health. So now we're going to talk about hiatal hernias. So hiatal hernias, also called diaphragmatic hernias, involve the protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. The esophageal hiatus is the opening of the diaphragm through which the esophagus passes from the thorax to the abdomen. And we have a nice graphic here. You see on the left you have the esophagus and the stomach, and the diaphragm is here at the level of the lower esophageal sphincter. Now you have in the middle the sliding hiatal hernia, which is an hernia that is going to go up and down depending on the stressors, right? And this is out of all the hernias, I would say this is the less complicated. And then the last one is the paraesophageal, in which the hernia is going to stay there. There is a good amount of stomach there, so it's going to stay there. Okay, so pathophysiology, hiatal hernia are classified as sliding hernias, which are most common, or types 2 to 4, paraesophageal or rolling hernias. In a type 1, the one we saw in the middle, sliding hernia, the esophagastric junction and a portion of the fundus of the stomach slide upward through the esophageal hiatus into the chest, usually as a result of weakening of the diaphragm. The major concern for a sliding hernia is the development of esophageal reflux, right? Because that brings as a consequence acid content, damaging the tissue of the esophagus, maybe little ulcers. Okay, type 2 is the gastroesophageal junction, remains in its normal intra-abdominal location, but the fundus and possible portions of the stomach graded curvature rolls through the esophageal hiatus and into the chest beside the esophagus. Okay, type 3, the gastroesophageal junction and the fundus, both the gastroesophageal junction and the fundus both herniate through the hiatus, with the fundus living above the gastroesophageal junction, right? And then we have type 4. This is serious. The colon, spleen, and pancreas, or small intestine, is found in the hernia sac instead of the stomach. Okay, this is tragic. So, key features of the hiatal hernias, the sliding hiatal hernias, you're going to have the symptoms of heartburn, regurgitation, chest pain, dysphagia, belching, okay? While in the paraesophageal, you are going to have breathlessness after eating, feeling of suffocation after eating, chest pain that mimics angina, okay, and the worsening symptoms is going to be on a recumbent position. Okay, so I'm gonna play a video about the sliding hernia, which is the most common. At this point you should be already mastering the lower esophageal sphincter, the diaphragm, and everything, okay?
This
I'm gonna
animation
put this on, I think it's on second
normal
55.
to stop the acid up into your esophagus. Here we show the valve opening and closing.
Okay.
In a sliding hiatus hernia, the sphincter and the top part of the stomach push upwards into the chest. A hiatus hernia can prevent the esophageal sphincter from closing properly. If this happens, acid from the stomach can pass into the esophagus and cause discomfort, known as heartburn. However, often hiatus hernias don't cause any symptoms. Sliding hiatus hernias are usually quite small. They can slide back and forth through the hiatus, so symptoms can come and go. Sometimes sliding and rolling hiatus hernias are present at the same time. This is known as a mixed hernia. This is the end of the animation. Click on the animation.
So you see, you have a better idea of how this hiatal hernia, sliding hiatal hernia, behaves. Okay. Now, the risks of volvulus twisting of a GI structure. The risk of volvulus, that's another term we need to learn. Obstruction, blockage, and strangulation stricture are high with these hernias. The development of iron deficient anemia is common because a slow bleeding from venous obstruction causes the gastric mucosa to become engorged and ooze. Okay, so we have in the paroesophageal hiatal hernia, we have they are close to the gastric veins. Okay, so we need to think about that when we analyze the map. Recognize the cues, the assessment. So most patients with hiatal hernia are asymptomatic, but some experience symptoms similar to those with GERD. Symptoms usually worsen after a meal or when the patient is supine. The barium swallow study with fluoroscopy is the most specific diagnostic test for identifying hiatal hernia. Rolling hernias are usually clearly visible. Okay, the rolling hernias are called also the paraesophageal. And sliding hernias can often be observed when the patient moves through a series of positions that increases intra-abdominal pressure. To visualize sliding hernia, an esophagogastroduodenoscopy may be performed to view both the esophagus and gastric lining. What are the interventions for this? So in type 1, the sliding hernia are usually treated medically. Treatment for type 2 through 4, that includes in the hernia, you're going to see content of the colon, the spleen. Do you remember? We just said it. Are treated based on type, severity, and symptoms and risk for serious complications. For patients who have or are at risk for volvulus, which is the twisting, okay, patients who are at risk for volvulus, bleeding, obstruction, strangulation, perforation, or respiration compromise, surgery is the approach selected. So non-surgical management in type 1 are similar to those for GERD. These include drug therapy, nutrition therapy, and lifestyle changes, right? I'm really concerned because the order of the non-surgical management should be lifestyle changes is first, nutrition therapy, and then drug therapy. But the conventional medicine starts with drug therapy, right? The primary healthcare provider typically recommends antacids or a proton pump inhibitor to control reflux and its symptoms. Okay. Action alert: when caring for a patient with hiatal hernia, education is one of the most important parts of nursing care. Follow health teaching as described for patients with GERD. So surgical management is going to be, I want you to remember also that when they are treating patients with the drug therapy, think about the PPI and the long-term effects, especially when the patient is not changing their nutrition and there is no lifestyle changes, right? So preoperative care, if the surgery is not urgent, the surgeon may instruct a patient who is overweight to lose weight before surgery. Any patient who is to undergo surgery for hiatal hernia is advised to quit smoking. Of course, we need to eliminate the causing agents, right? The stressors. Operative procedures, surgical repair can be done transabdominally or transthoracically. The transabdominal approach can be done an as open procedure or laparoscopically. Why we need to get to the point of get a surgery for an approach transabdominally or transthoracically? If we can change and prevent, if we can change our nutrition, lose weight, right, start lifestyle changes, we can prevent all these conditions. Surgery involves fundo application, in which the stomach fundus is wrapped around the distal esophagus, and that's called the Nissen fundo application approach. Laparoscopic Nissen fundo application. One approach is to conduct the transabdominally, means an upper surgery to do the Nissen. Another approach is to do the same laparoscopically. Yeah? It's a minimal invasive surgical procedure commonly used for hiatal hernia repair. Prepare the patient undergoing a transthoracic approach. Wow. For a chest tube, you see, it's not necessary if you really follow a proper nutrition, again, lifestyle changes, and you lose weight. So an esogastric tube, which will be present after surgery. This will be inserted during surgery and remain in place for several days and put the patient in high risk for sepsis, infection, pneumonia, hospital-acquired pneumonia, blah, blah, blah. Post-operative care, patients having the LNF procedure, okay, is the Nissen fundo application procedure, laparoscopic, LNF, laparoscopic Nissen fundoscopy procedure, or paresophageal repair via laparoscope are at risk for bleeding and infection. Okay, so here they are explaining how the Nissen fundo application is done. As you can see in the graphic A, part of the fundus is taken and wrapped. There is no resection or separation from the stomach to esophagus. Okay. Patient and family education, postoperative interaction for patient having laparoscopic Nissen fundo application or paresophageal repair via laparoscope. The paresophageal means that the hernia is level 2 to 4. Okay, sorry. So consume a soft diet for about a week. Avoid carbonated beverages, tough foods, and raw vegetables, right, that are difficult to swallow. That's very important. Do not drive for a week after surgery, and common sense, do not do any heavy lifting, right? So nursing safety priority, that's good to know. NCLEX alert. Nursing interventions. The primary focus of care after conventional surgery for a hiatal hernia repair is the prevention of respiratory complications. Always, anything related to the upper part of the body is going to have the risk for respiratory complications. Elevate the head of the bed at least 30 degrees to lower the diaphragm and promote lung expansions. Help the patient out of bed and begin ambulation as soon as possible. Be sure to support the incision during coughing to reduce pain and prevent excessive strain on the suture line especially in patients with obesity. Now we have best practice for patient safety and quality care, assessment of post-operative complications related to fundo application procedure. And again, the fundo application is the wrapping of the fundus, the part of the stomach around the LES, the lower esophageal sphincter. So what complication? Temporary dysphagia. So what are we going to see? Difficulty swallowing when oral feeding begins. Gas bloat syndrome, difficulty belching to relieve distension, atelectasis, pneumonia, dyspnea, chest pain or fever. Another complication is obstructor nasogastric tube, nausea, vomiting or abdominal distension is going to be noted, and or non-draining nasogastric tube. For the patient who has undergone an opening procedure, right? That's an open approach. Provide post-operative interventions present in Chapter 9. Okay, regarding incentive spirometer, deep breathing, and prevention of venous thromboembolism. And I showed you in class, and I'm going to play it again, the way we are checking on deep thromboembolism, the Homan signs, okay?
The Homan sign is a classic, yet fairly insensitive test for DVT or deep vein thrombosis. The test is simply pain in the calf muscle with passive dorsiflexion of the ankle.
Thank you so much. So you need two symptoms in order to diagnose DVT, common signs. So the patient needs to have pain when you dorsiflex. Okay, this test can be done by another person, another provider, not but the same patient that feels to dorsiflex. It has to be a passive dorsiflexion. Okay, so you could do the test when the patient is sitting or when the patient is in the bed. So also signs and symptoms of this DVT are swollen leg, is going to be red, it's going to be warm to touch, right? So that's why we are doing this common sign. Patients with large hiatal hernias are at the higher risk for developing respiratory complications. The patient will have a large bore diameter nasogastric tube to prevent the fundo application wrap from becoming too tight around the esophagus. So they put the tube in order to secure the width of the wrapping, right? Initially, the NG drainage should be dark brown with all blood. The drainage should become normal yellowish green within the first 8 hours after surgery. And this is for me extremely important. I have not seen questions or information in my HESI or NCLEX reviews about this particular fact, but if you are doing assessment of an NG tube, you have to pay attention in the color, okay, of the drainage. Check the NG tube every 4 to 8 hours for proper placement in the stomach. Yes, this information is required, but I haven't seen the dark brown fact that becomes a yellowish green. It should be properly anchored so that it does not become displaced because reinsertion could perforate the fundo application, correct? Okay, so monitor patency of the NG tube. We know that. The NG tube is irritating, so provide frequent oral hygiene to minimize pain. Assess hydration. Document intake and output. Adequate fluid replacement helps thin respiratory secretions. Beginning with clear fluids, the patient gradually progresses to a near normal diet during the first 4 to 6 weeks. Some foods, especially caffeinated or carbonated beverages and alcohol, are either restricted or eliminated. and we prefer to be eliminated, right? Because that is one of the causative agents. The food storage area of the stomach is reduced by the surgery, and meals need to be smaller and more frequent. Carefully supervise the first oral feeding because temporary dysphagia is common. Continuous dysphagia usually indicates that the fund application is too tight and dilation may be required. Okay, so that's why they put the NG tube to avoid the fundal application to be tight. Some patients develop gas bloat syndrome, in which patient cannot voluntarily eructate, belch. The syndrome is usually temporary but may be persistent. Okay, teach the patient to avoid drinking carbonated beverages. Again, we have to eliminate that. And eating gas products foods, especially high fat foods. High fat foods. Your pork, your sausages, right? High fat, your fried foods. Chewing gum and drinking with a straw. Chewing gum and drinking with a straw. Okay? We don't want to promote gas bloat syndrome. Chewing gum. Transition management. Patient undergoing upper surgical repair require activity restrictions for 3 to 6 weeks post-operative. For laparoscopic surgery, activity is typically restricted for a shorter time. For long-term management, educate the patient on appropriate nutrition, use of stool softeners or bulk laxative to prevent constipation and straining. Honestly, if you follow your high fiber, your walking, and your fluids, you shouldn't have any problem with bowel movement. And if you take your celery juice, of course, you're gonna have a nice, easy, soft bowel movement. Avoidance of people with a respiratory infection. Development of a respiratory infection with coughing can cause the incision of the fundal application to dehisce. Esophageal tumors, we are changing subjects right now. Although esophageal tumors can be benign, most are malignant, meaning cancerous, and the majority develop from the epithelium. Squamous cell carcinoma of the esophagus are located in the upper 2/3 of the esophagus. That's the differential. So if you see any malignancy in the upper 2/3 of the esophagus, okay, is a squamous cell carcinoma. Adenocarcinoma, the most common type of esophageal cancer, usually occurs at the distal end of the esophagus and the upper portion of the stomach. So that's the adenocarcinoma, okay, in the distal end and upper portion of the stomach. Esophageal mucosa is richly supplied with lymph tissue. There is typically early spread of tumors to lymph nodes. So metastasis is going to be common and can cause thickening or invade deeply into surrounding tissues. Esophageal cancer is not it's not a joke. Primary risk factor associated with the development of esophageal cancer includes alcohol, again, diets chronically deficient in fresh fruits and vegetables. It's all about nutrition. Diet high in nitrates. That means your all the food that is coming in cans, in packages, okay. And nitrosamines found in pickled and fermented foods, okay. Malnutrition, if you love to eat your pickled vegetables, prepare yourself at home, right? You can do that. Some apple cider vinegar. You can use your Himalayan salt, and you put some water and you put the pickle, the vegetables there. You prepare yourself, right? You ferment it from cabbage all the way to onions, carrots. Do it at home. Malnutrition, obesity, smoking, untreated care. Okay. So the nurse is reviewing a client health record. Which of the following assessment finding would the nurse identify that increases the client risk for development of esophageal cancer? So we just spoke about malnutrition, alcohol, and current smoker. Low dairy intake is not an option, and fresh fruit consumption is not. Assessment for risk factors, especially if it's a man, regardless of race, of ethnicity, have a higher incidence and higher mortality rates associated with esophageal cancer. Cancer of the esophagus is a silent tumor in its early stages. Listen to this. By the time the tumor causes symptoms, has spread extensively. Okay? So when the cancer becomes symptomatic, it's already spread. The most common symptoms of esophageal cancer is dysphagia, difficulty swallowing. Weight loss often accompanies progressive dysphagia and can exceed to 20 pounds over several months. The disease is often terminal. That's why I told you it's not a joke. Diagnosis assessment, and you see all the risk factors. All the risk factors: alcohol intake, diets chronically deficient in fresh fruits and vegetables, the consumption of high in nitrates, malnutrition, obesity, smoking. All these are preventable factors. Diagnostic and gastroesophageal duodenoscopy with biopsy is performed to inspect the esophagus and obtain tissue specimens for cell studies and disease staging. Cancer staging workup is performed often by endoscopic ultrasound. Position emission tomography, the PET, may identify metastatic disease with more accuracy than a CT scan, and the reason is because when they do the PET scan, they inject through Ivilan with a special agent that is able to highlight the areas in where the cancer is spread. Okay. Key features: esophageal tumors, persistent and progressive dysphagia, most common feature as we described before, halitosis, which is an offensive smelling breath, odinophagia, painful swallowing. Look all the terms that we are learning, and you really need to, when you present the report to the following nurse or the primary healthcare provider, right? The patient here and so is coming the first visit to the gastrointestinal, to the gastroenterologist, presenting with halitosis, complaining of odinophagia, complaining of dyspepsia, dysphagia, this and that. You need to master this, okay? Feeling of food sticking in the throat, right? Regurgitation, changes in bowel habits, hoarseness. Take action intervention is going to be multimodal therapy, could include surgery, resection, radio, chemotherapy, radiation. Okay. Non-surgical management is going to focus on nutrition and swallowing therapy, chemotherapy, radiation, and chemoradiation. That is considered non-surgically, right? Because chemotherapy is going to be given IV, and radiation is not surgical. Photodynamic therapy and porphymer sodium and other therapies. So I want you to see what a photodynamic therapy with porphymer sodium is. So I'm gonna play the video here.
One option for destroying abnormal cells in your esophagus is called photodynamic therapy. Before the treatment, a light-sensitive medication is injected into a vein in your arm. During the next 2 days, this medication is absorbed by all the cells in your body. It builds up to a much greater degree in fast-growing cancerous or precancerous cells. Once the medication has been absorbed, your doctor uses an endoscope to guide a laser light down your esophagus to the site of the abnormal cells. The light from the laser activates the light-sensitive medication in the abnormal cells and destroys them. Typically, healthy cells grow back in their place. This procedure may be repeated a number of times, with several months in between treatment.
Okay, thank you so much. So nutrition and swallowing therapy. What are we gonna do? We're gonna review the nutrition status. The registered dietitian determines the caloric needs for the patient to meet daily requirements. Of course, because I am sure the patient, due to the dysphagia or odinophagia, right, is not eating properly to avoid pain, and probably lost weight because of this. To keep the esophagus patent, position the patient upright for several hours after meals. To keep the head of the bed elevated to a 30-degree angle or to more to prevent reflux. Semi-soft foods and thickening liquids has to be included in the therapy. Liquid supplements are used between feedings to increase caloric intake. Ongoing efforts are made to preserve the ability to swallow, right? That's the most important. But enteral feedings, tube feedings, may be needed temporarily when dysphagia is severe. In patients with complete esophageal obstruction or life-threatening fistulas, and we know the fistula is the connection from one canal to the other, right? The surgeon may create a gastrostomy or jejunoscopy for feeding. Collaborate with the speech-language pathologists to help the patient with oral exercises to improve swallowing, and with the occupational therapy for feeding techniques. Nursing safety priority, NCLEX alert safety when the patient with a esophageal tumor is eating or drinking. Recognize that you must monitor for signs and symptoms of aspiration, which can cause airway obstruction, pneumonia, or both, especially in older adults. That's why I took a little of your time in class to review the location of the canals. The larynx, behind that is the trachea, and behind that is the pharynx. Okay, so in case you are the type of student memorizing facts, which is the wrong approach to prepare for your NCLEX, you need to know your map. If you know your map, you're gonna be able to think, in a logical way of where the anatomy, how is the anatomy in that area, and you can respond and select your responses in an accurate way. Okay. Chemotherapy and radiation. Chemoradiation is a treatment for esophageal cancer that involves the use of chemotherapy at the same time as radiation therapy. Photodynamic therapy and porphymer solution, we spoke about this, is used as palliative treatment for patients with advanced esophageal cancer. It can relieve or make swallowing somewhat easier. That's the photodynamic therapy. We saw the video, right? Other therapies, esophageal dilation, may be performed as necessary throughout the course of the disease to achieve temporary but immediate relief of dysphagia. What is esophageal dilation? Let's watch the video so we are informed of what are the possibilities for the patient, right? And everything can be prevented. All these diseases can be prevented.
With a normal swallow, food, pills, and liquids are able to smoothly move from the mouth, through the esophagus, and down into the stomach without any difficulty. However, a blockage of some type can develop in the esophagus, leading to food and pills getting stuck, causing choking, gagging, and even regurgitation. This blockage can be due to a web, stricture, or stenosis of some type. The most common way to deal with such closures is to stretch it open. Known as esophageal dilation, this can be accomplished with bougies of increasing diameter or by inflating a balloon. Shown first is serial dilations using esophageal bougies. Bougie insertions are performed through the mouth and past the area of narrowing. Larger and larger diameter bougies are inserted one after another to slowly stretch open the esophagus. Balloon dilation is accomplished by first inserting an endoscope to where the stricture is located. A deflated balloon catheter is then inserted traversing the stricture. At that point, the balloon is inflated, thereby selectively stretching the area open while under endoscopic visualization. After a short period of time, the balloon is deflated and withdrawn. Both methods are commonly used with similar success rates, though one method may be preferred over the other depending on patient and stricture factors.
Thank you so much. The reason I'm playing these videos over and over is to invite you to change your lifestyle habits and to conduct yourself into the proper nutrition. All these diseases, at least in this chapter, are preventable, okay? Also, they can approach the condition with esophageal stenting. They can put a stent there, right? A stent can be offered as palliative care for patients who are not surgical candidates. Probably the patient is having already metastasis in tissues close to the esophagus, right? Or they are terminal. Stenting can be performed with metal, plastic, or biodegradable mechanisms that are intended to relieve obstruction, and sometimes the quality of the stent even damage further the tissue. Targeted therapies such as trastuzumab may be given IV every 3 weeks in addition to chemotherapy. That's another medication, and we will need to double check the side effects. Surgical management. The purpose of different types of cervical resection may vary from cure to palliation. Esophagectomy is the removal of all or part of the esophagus. Yes, and is sometimes selected as the first line of therapy for esophageal cancer. It's the first line of therapy. For patients with early stage cancer, a laparoscopy assisted minimally invasive esophagectomy may be performed. Most patients require conventional open surgery because of tumor size and metastasis by the time they are diagnosed with the disease. Remember that in early stages it's not going to give you any signs, and then dysphagia is going to be present when it's more severe or in later stages. Okay, so okay, so that is the image, esophageal dilation. Preoperative for patients undergoing esophagectomy. Advise the patient to stop smoking 2 to 4 weeks before surgery to enhance pulmonary function. Intensive preoperative respiratory rehabilitation and nutrition support may be ordered. Supplementation is given orally, but some patients require tube feeding or parenteral nutrition. Monitor the patient's weight and intake and output, treat dental disease, instruct the patients to practice meticulous oral care 4 times daily to decrease the risk for post-operative infection. If we change our lifestyle habits and we start increasing our oral care, dental care, better nutrition, we lose weight, we stop smoking, we stop alcohol consumption, we don't even need to consider we're going to get into these problems. Operative procedures, there are numerous types of esophagectomies. The necessary extent of lymphadenopathy and the surgeon's preference also influence surgical approach. Surgery may be minimally invasive or open, but I'm just letting you know the amount of lymph nodes around that area is huge. Okay, there is a lot of lymph nodes, so sooner or later they have to complete full esophagectomy. Post-operative care, and the risk of metastasis is high because the amount of lymph nodes, right? Once one lymph node is infected, then we are going to start the domino effect. Post-operative care, keep the patient in a semi-Fowler or high Fowler position to support ventilation and prevent reflux. We are talking about post-operative after the esophagectomy. Ensure the patient of the chest tube drainage system and monitor for changes in the volume or color of the drainage. And that's good to know. NCLEX alert. We need to know everything about chest tubes also. It's going to be present. Action alert, respiratory care is the highest postoperative priority for patients having an esophagectomy respiratory care, right? Because of the location. For those who had traditional surgery, intubation with mechanical ventilation is necessary when they said traditional surgery is open, right? It's not laparoscopic. For at least the first 16 to 28 to 24 hours. Pulmonary complications can rise, such as atelectasis and pneumonia. The risk for postoperative pulmonary complications is increased in the patient who has received preoperative radiation. Okay, preoperative radiation, because those tissues are already kind of damaged, and patients who usually receive radiation are having the immune system is going to be compromised. Okay, so the risk for complications is high. Once the patient is extubated, support deep breathing, turning and coughing every 1 to 2 hours. Assess the patient for decreased breath sounds and shortness of breath every 1 to 2 hours. Provide incisional support and adequate analgesia to enhance effective coughing. Nursing safety priority. Monitor for symptoms of fluid volume overload, particularly in older patients and those who have undergone lymph node dissection. Assess for edema, crackles in the lungs. Again, guys, review how your technique, your skills on how to position your stethoscope, how your lung sounds are. Please. And decrease jugular venous pressure. Many questions in NCLEX, they are going to describe the lung sounds and you need to select which one it is. You can, the nurse position the stethoscope in this way, this area, and she can hear, adventitious, this and that, Select which lung sounds it is. They have crackles, stridors, wheezing, okay? You need to know that. Critical care nurses assess hemodynamic parameters such as cardiac output, cardiac index, and systemic vascular resistance every 2 hours to monitor for myocardial ischemia. Observe for atrial fibrillation. What is cardiac output? The formula we know already: a stroke versus multiplied by heart rate. That gives you the cardiac output, right? Atrial fibrillation, I think you're going to learn next semester. Wound management is a major postoperative concern. Provide direct support to the incision during turning and coughing to prevent dehiscence. Wound infection can occur 4 to 5 days after surgery. Okay, after surgery. Whenever you feel that everything is going well and the operation was a success, boom, you're having a wound infection. Leakage from the site of anastomosis, and we know anastomosis is the union of two different parts, right? It's a dreaded complication that can appear 2 to 10 days after surgery. All oral intake is discontinued and does not resume until the site of the leak has healed. Mediastinitis, which is the inflammation of the mediastinum resulting from an anastomotic leak, can lead to fatal sepsis. Dehiscence means that the incision is reopened, and anastomosis is the connecting of two parts. I'm just reviewing. I'm sure you know this. Just reviewing. Critical rescue. After esophageal surgery, recognize fever, fluid accumulation, signs of inflammation, and symptoms of early shock, tachycardia, tachypnea. Okay. A nasogastric tube is placed intraoperatively to decompress the stomach to prevent tension on the suture line. Monitor the NG tube for patency and carefully secure the tube to prevent dislodgement, which can disrupt the sutures at the anastomosis. Do not, okay, irrigate or reposition the NG tube in patients who have undergone esophageal surgery unless ordered by the surgeon. And this is NCLEX maximum alert. Okay, in a patient that has undergone esophageal surgery, this and that, actions, with a nasogastric tool include all of the above. Okay, select all that apply, and then they are gonna put you do not irrigate or reposition the NG tube, and you don't select that one, right? Initial feedings usually begin through the jejunostomy tube, which is the J tube. Do not aspirate for residuals because this increases the risk for mucosal tearing. Okay, a variant swallow is performed on the 7th postoperative day. If no anastomosis leak are seen, the NG tube is discontinued. What is a barium swallow? Let's watch this video. We're almost done, but this is a beautiful chapter, gastrointestinal. So there is a fluid that the patient is drinking, and the fluid is gonna highlight the area, right? And at the same time, an X-ray is going to be done. Professor Matalana is selecting videos that are short but are very informative for you guys to understand. The only thing you need to do is you just need to play this video with the chapter's information, let it go. I included videos, explanations. You don't need to look for further explanations, terminology. Everything is well defined. Just play the video and study and take notes on the NCLEX material, and that's good to know. That's all you need to do, right? Okay. You can walk while playing this video. You can do the dishes. You can do your bed. You can even be driving. Okay, so you study at the same time that you are listening to the information. Repetition is going to get you acquire the knowledge. Care coordination and transitional management. Long-lasting side effects such as fatigue and weakness, okay, are common side effects, right? So best practice for patient safety and quality care. Managing the patient with NG tube after esophageal surgery. And After this surgery, the patient will have long-lasting side effects such as fatigue and weakness. Remember that area in which the larynx is in front, the trachea is behind, and the pharynx is right behind all of these canals, right? So that's why when they are handling, they are managing, they are making surgery, all the three are going to be affected in some way. Managing the patient with NG tube after esophageal surgery. Check for tube placement every 4 to 8 hours. Make sure the tube is patent and draining. Do not irrigate or reposition the tube without a healthcare provider's order. Please provide meticulous oral and nasal hygiene every 2 to 4 hours. And as I told you, this area involving the throat, right? The throat that is on top of the larynx, the trachea, and the pharynx has an opening that connects the nasal canal, and even there is another opening for the ears, right? So that's why provide meticulous oral and nasal hygiene every 2 to 4 hours. Okay, keep the head of the bed elevated to at least 30 degrees. Observe for leakage from the anastomosis site indicated by fever, fluid accumulation, and symptoms of early shock, tachycardia, tachypnea, altered mental status. Once the patient is discharged to home, ongoing respiratory care remains a priority. Give the patient and caregiving instruction for ambulation and incentive spirometer use. Nutrition, nutrition, nutrition. Teach to eat small, frequent meals containing high caloric, high protein food that are soft and easily swallowed. Teach the value of using supplemental shakes. Emphasize the importance of sitting upright to eat and remaining upright after meals. Teach patients to monitor their weight at home and to report a weight loss of 5 or more in 1 month. And washing, remind them to contact the healthcare provider immediately if signs of respiratory infection develop. Patients should stay away from people with infection and avoid large crowds. Teach the patient that dysphagia, which is difficulty swallowing, or odynophagia, which is pain when swallowing, may recur because of stricture reflux or cancer recurrence. There's a nice article about evidence. I think it's the last topic, esophageal trauma. Trauma to the esophagus can result from blunt injuries, chemical burns, surgery, or endoscopic, although rare, or the stress of continuous severe vomiting. When excessive force is exerted on the esophageal mucosa, it may perforate or rupture, allowing the caustic acid secretion to enter the mediastinal cavity. These tears are associated with a high mortality rate related to shock, respiratory impairment, or sepsis. Yes. Common causes of esophageal perforation include straining, seizures. Professor Matalana, why seizures? Because some of the healthcare workers, sometimes they are introducing stuff when the patient is having a seizure, and they are introducing stuff in the mouth. Okay. Or maybe the patient is falling. There is a trauma based on where the patient ends up on the floor. Trauma, foreign objects, instruments or tubes, complication of esophageal surgery, ulcers, chemical injury. You have to assess for airway patency, breathing, chest pain, dysphagia, vomiting, and bleeding as the priorities for patient care. An endoscopic study may be requested to evaluate tears or perforation. A CT scan of the chest can be done to assess for the presence of mediastinal air. And whatever I'm going to read right now in yellow is that's good to know. Nursing interventions after the injury. Keep the patient NPO, right, to prevent further leakage or esophageal secretions. Esophageal and gastric suction can be used for drainage and to rest the esophagus. Esophageal rest is maintained for more than a week after injury. Allow the initial healing of the mucosa. total parenteral nutrition is ordered. The healthcare provider prescribes broad-spectrum antibiotics, right? High-dose corticosteroids to reduce the inflammation may be administered to suppress the inflammation, yes. Opioid and non-opioid analgesics may be prescribed for pain management. When caustic burns involve the mouth, topical agents such as viscous lidocaine may be used. And if non-surgical management is ineffective in healing injured esophageal tissue, the patient may need surgery to remove the damaged tissue. Those with severe injuries may require resection or part of the esophagus with a gastric pull-through and reposition or replacement by a bowel segment. So they remove that area and they put parts of the bowel over there. A gastrotomy tube, the G tube placement may be needed to meet nutrition needs while healing. So that's the end of the chapter. We have mastery question here. A client who had the laparoscopy needs a fundo application. We know the wrapping of the fundus of the part of the stomach around the lower esophageal sphincter is being discharged to home. So this patient had this laparoscopic surgery and is going home. Which of the following client statements require further teaching? So we are looking for the wrong answer. I should eat a soft diet for at least 1 month. That's good. My surgeon will remove my wound dressing after a week. Okay. I should avoid any heavy lifting at this time. Is not only at this time, but you should avoid heavy lifting for a long period. A small amount of nausea and vomiting is normal after L and F. I will need to take anti-reflux medication for the rest of my life, and everything is correct except for the heavy lifting. A client is recovering from trauma to the esophagus. Which of the following actions would the nurse include in the plan of care? Administer TPM per order? Yes. Monitor secretions from gastric suction? Yes. Maintain MPO status and give eye chips? No, you don't even want to give anything. If the patient is MPO, it's MPO, nothing per oral, right? Maintain esophageal rest for at least 1 month. No, you wanna, you want to make sure that the patient is going to be safe. Determine the ongoing need for analgesia. Yes. So all these answers are in the student resources of your electronic version. You just select the chapter and you can see the NCLEX, the answer key that includes the NCLEX and also the mastery questions. So it was a pleasure to complete this chapter, Concepts of Care for Patients with Oral Cavity and Esophageal Disorders. When we come back, we are going to study another area of the gastrointestinal. We are going by parts. We started in the mouth, then we went down to the esophagus. We are getting into peptic ulcers, duodenal, and we are going all the way down. Okay, thank you guys.